just take your seats now. Welcome to this session, Post-Brexit Oncology, New Horizons in the NHS. I'm Ed, I'm from Bristol, and my co-chair is Gren, who's a local man and a kidney cancer expert. We're going to be joined by 4 experts in their field to talk about the future. What this really means, what we want to know is what are we going to be doing in the next few years, post-Brexit, in a financially challenged environment. So I'm going to introduce our first speaker, who's Archie Fernando, who's an expert in retroperitoneal fibrosis, testis cancer, upper tract TCC, but also renal cancer, and that's what she's going to talk to us about today. She's from Guy's, appointed there in 2015, and I'm really looking forward to her talk. So Archie, welcome.
Thank you very much for inviting me to talk about post-Brexit renal cancer. So one of the challenges I had putting together this talk was really about how to approach such a wide subject, but still kind of keep to the brief. And I thought what I might do is sort of think about what the ideal management of renal cancer might be in 2017, how we can deliver that in a personalized way in this kind of newer healthcare context. And what I mean by that is when our healthcare systems were first designed, they were designed with very sick people in mind, people in extremis who really needed our help. They needed aggressive treatment. They knew very little about their diseases. They needed a lot of support through their treatment. But now the patients are very different. They're much more patients who are going to be living with chronic illness. They're much better informed. And so they're a very different type of patient to who we have been treating to date. And how do we deliver all of this within the constraints of Brexit and a national health service? So when we think about ideal management and delivering it in a personalized way, I think there are 2 key concepts that we understand about renal cancer that we have to incorporate into a management strategy. The first is this, that renal cancer is not one disease. It is a whole basket of different diseases made up of these separate components. For example, if you were to take a small renal mass that is spontaneous in someone with a very good performance status, it's high grade, has a low Padua score, that's a very different type of thing to someone with multiple small renal masses and hereditary papillary renal cancer, which again is different from someone with a large renal mass, which is low grade, have poor renal function, but excellent performance status. So distinctly different diseases requiring distinctly different treatments. This is the second concept that I think is going to change how we manage renal cancer. We've heard a bit about it this week. So we thought that VHL was going to be the key, but now our understanding of this sort of genetic iceberg is so much more advanced than that. We are able to identify and profile people's renal cancer in a way that we haven't been able to before. We can also even predict which of the small renal masses are going to be T3 on histology, which of them are going to respond to different treatments, and which are at higher risk of relapse. So we're in a position now, more than ever, to provide really bespoke, individualized treatment. And in order to deliver this, we have to have 2 things in our diagnostic pathway. Genetics, at least for those who are in whom it's likely to change management, if not everyone. And we've seen, it's on Twitter, so it's true that the cost of genetic testing is going down all the time, much more affordable than it's ever been. And this second thing, which is biopsy. There have been still some discussions this week about whether we should biopsy or not. I think really that boat sailed when our own national data showed such high rates of benign tumors in people undergoing partial nephrectomy. We know that biopsy is now safe. It's certainly safer than some of the other treatments that we're proposing, and it will prevent overtreatment. And this is the other thing. This is, I have to thank the TraceX group for this slide. With biopsy and genetics, we are now able to sort of profile people into the type of tumor that they have, what that tumor is going to go on to do, and what treatments are going to work for them. So we've talked about what might be an ideal diagnostic strategy and how we can develop and how we can deliver it in a personalized way. What about the treatments? So when I'm thinking about treatments, I'm thinking about what patients want. What they want is a treatment that has minimal morbidity, is not really going to affect their quality of life, but is going to stop the cancer from shortening their life, or prevent the cancer from shortening their life. And active surveillance has a lot to recommend it in this regard. We also know with the development of drugs, which I'll come on to a bit later, that down the line, if the patients were to progress, you can rescue that situation. Of course, no talk on renal cancer is complete without a picture of the Da Vinci robot. And really, this is to show how much progress we've made in renal cancer surgery with using robotics. We're able to deliver safer, less morbid surgery in more complex situations. In parallel with this, our open surgical techniques have also improved. We're able to operate on more and more complex things in safer ways that patients can tolerate much more. This is really just to show we need to move away from that idea that if it can't be done robotically, it should be a radical nephrectomy robotically or laparoscopically. But really, it's more about deciding what's the correct operation for the patient and then working out how you deliver that. What we're not so good at is this. So there's, in the recent round of national audit, there's still over 300 surgeons in 128 centres delivering cancer surgery. So all the orange ones are cancer operations. And whatever your feelings are about centralization of surgical care, I think we have no choice but to centralize overall care for renal cancer. And I'll come on to that a little bit later and all the reasons why I say that. I'm just going to put up one slide on ablation. Don't you hate it when all these papers say, at the end they go, we need more RCTs, we need more RCTs, we need more RCTs. It's one of my pet peeves. But really, for ablation, we just cannot move forward without a trial of ablation versus partial nephrectomy. We cannot work out the place that ablation has in renal cancer surgery without that. Where we have been really good is the drugs. We have more drugs available to us now than ever before. They're more effective than before. They're more well tolerated than before. Yes, they're expensive, but over time, that expense will go down. This is what the drugs have done for survival. Currently, at least half of our patients with metastatic kidney cancer get to 5 years or more. And we're not that far off getting over 80% of our patients to 8-10 years with metastatic cancer. So the drugs are really transforming our options for managing these patients. So when you're dealing with renal cancer, you should be able to provide the patients with the diagnostic tools that will help decide their treatment. You should be able to provide those treatments. You should be able to deal with the complications of that. You should have access to the trials. And even more than that, research. The centralization of care improves access to research, reduces cost of research, and increases recruitment. So I think this slide, I hope, convinces you why we have to move inevitably towards proper centralization of renal cancer care. So now that I've talked about those three things, what are the constraints that Brexit are going to put on us? Less staff, less money, less collaboration with the EU. And so what I've done is I've just put together what I think is a model that would work for renal cancer patients in the NHS moving forward. It's just my idea, so I'd be really interested to hear what you think about it. So let's imagine that centralized care is like a conveyor belt in the NHS. The first is stopping people getting even near the conveyor belt. Last week was World Renal Cancer Day, and they had sort of a questionnaire about what people know about renal cancer, and only about 5% of people know that renal cancer is caused by obesity, or that obesity can cause renal cancer. The second thing is working out whether patients even need to ever get on the conveyor belt. They've been referred, they've got a low life expectancy, they're never really going to be bothered. Don't even engage them with this conveyor belt. The next thing is using the diagnostic pathway with the tools that we talked about to decide which of these three sort of treatment strategies they might go into. Now, you might say that's how your clinic looks like now. That's the sort of thought process that you use now. But here's the key difference. In order to save money, we have to get people off the conveyor belt. You just cannot have people that are getting on with increasing numbers of renal cancer and no one being pushed off the conveyor belt. And this is where, for example, so if you've done surgery for a T1A tumor with a clear margin, what's the chance of that recurring? It's pretty much never really. So could you discharge that patient? Could we put the onus on follow-up with the patient? So we tell the patient you need to have a CT at 3 years and 5 years. It needs to be a contrast of your abdomen and pelvis. The patient can then have that with their GP. They can pay for it privately, or they can arrange it in some other way. And then they will feed back that result to you. I think we have to move away from this idea that you need to look the patient in the eye before you make a decision about their treatment. You've got to see them in the clinic after their surgery so you can check that the registrars close the wounds properly. You've got to catch up with them every 6 months, every year, just to see how they are. Patients will let you know if there is a problem. And I think we need patients to engage in care in order to have a model that is good, but also financially viable. If patients go onto surveillance, the idea is that they live a normal life with their cancer, not being constantly reminded of it, in charge of when they have their checks, and they re-engage with the process if they need to. Patients who are on medication can be monitored at home. They know what to look out for. They can check their blood pressure at home, and they can feed that back to you. And it may seem like I'm talking about futuristics, talking about virtual healthcare, but actually a lot of patients already have access to smartphones. They have the ability to download an app, and that is all you need in order to upload data. They can check their blood pressure at home, they can have their blood tests done locally. And a lot of patients prefer having that kind of power over their own healthcare. So although it seems like Brexit is all doom and gloom and we are dealing with a slightly impossible situation, I hope that through the talk and with consideration of this kind of model, we might be able to step into the light. Thank you.
Thanks, Archie. That was really thought-provoking. Any questions from the audience? If you want to make your way to the microphone. We've got one on the iPad here. Will all nephrectomy be robotic soon? I don't think so. I don't think that all nephrectomy needs to be robotic. I think there is certainly still a role for open surgery in the high cable stuff that we see, or even any cable stuff that we see. I think we should be aiming to deliver high-quality, safe surgery in whatever technique that comes. So I think it's less about robotics, it's more about the quality of the surgery that you can deliver. Okay. And just a question for myself, that the biopsy and then genetically typing each individual tumour, in the future, is that going to be a way of selecting patients who might be suitable for surveillance because you know the biology of that tumour and can predict the future of how it's going to behave? And if that's the case, how far away are we from that, do you think?
Yeah, absolutely. I mean, if I had a renal tumor, I want to go to the clinic, I want my urologist to biopsy me there, and then I want them to ring me and say, look, this is what your type is, this is what is going to happen, these are your choices. I want power in that, and I don't think that we're that far away from it. We've heard talks, Simon Crabb gave a great talk earlier in the week about how genetic testing is already commonplace in a lot of different diseases. We use genetics a lot in our renal cancer clinic, and we're not that far off from being able to type patients. The question is, when are we going to get to 100% accuracy with the typing? That's probably slightly far away, but we can definitely have much more information about our tumors than we are currently getting.
Brilliant. Question there?
I can foresee that soon we will be getting nephrectomologists, and how it will impact on the general urology.
It's a good question. I think as clinicians, as people who went into medicine, understanding the art of medicine and feeling like our connection with patients was really of utmost importance, it's difficult to swallow this way that medicine is going. But technology has been embraced in every single other sector. And if we don't embrace the technology and deal with what our patients want rather than what we are trying to hang on to, we're going to be left behind and we're really going to be struggling. I think the NHS has always been reactionary. Things have been forced upon them. I think as an association with Brexit happening, we can really set an agenda for future for how we manage our patients in the future. And we just have to move away from these ideas that we have. We're still delivering excellent care for the patients, just not how we were taught to deliver it. In answer to your second bit about general urology, I think there are trainees out there who would like to specialize in general urology, and why not? Should you be having a vasectomy done by someone who does the occasional vasectomy, similarly for circumcision or similarly anything else, I think we're going towards specialization, and there's no reason why people shouldn't specialize in general urology as well.
That's great. Thanks, Archie. That's fantastic. Thank you very much.
So now it gives me great pleasure to introduce Param Marippan, who's my good friend from the East Coast. Param's certainly the busiest cystectomist in Scotland and probably one of the busiest in the UK. He sits on the NCRI Bladder CSG and has been instrumental in setting standards for bladder cancer care in Scotland via the quality performance indicators.
Thanks, Graham. Thanks for the nice introduction. So when Ben and Joe approached me by email, actually, saying, horizons for the NHS. So the first thought that crossed my mind was, what horizon? We may have to hunt for one. Puns aside, the horizon looks interesting, exciting. We are starting to have a better picture through genomics, looking at the molecular pathways, and certainly this has opened up avenues for targeted treatment. We're now manipulating the immune system with checkpoint inhibitors. Whilst at the moment it's being used in advanced cancers, we may eventually be able to use them, for example, in BCG failure. However, let's take a step back and look at where we are at the moment. Thankfully, the incidence of bladder cancer is dropping, expected to continue to drop. Good news. However, we are living in an environment where we have more patients living with cancer, particularly those above the age of 65. And this is putting a huge strain on the NHS and its resources, and certainly has potentially implications on how we manage our patients. Bladder cancer is certainly sitting at the wrong end of the spectrum of this scale of patients' experience. We haven't been doing very well. And if you speak to patients, this is a survey done by Fight Bladder Cancer, there is a theme of poor communication and neglect, essentially. Survival-wise, we haven't been doing very well. We've not beat the 55% mark for a long time, and it seems to be actually on the downward trend. And across the board, there is significant inequalities of health, with, unfortunately, Scotland lagging significantly behind, well below the European average. Possibly one of the reasons why we have QPIs to hopefully unify standards, address these inequalities, and improve outcomes. So I've tried to stick with the brief of a cash-strapped NHS in times of uncertainty, and at the same time trying to touch on several aspects, not a comprehensive list, but just 6 areas, sticking to the principles of keeping things simple, making sure that we get down to the basics. There's lots of it that we still haven't achieved very well, contributing to local clinical trials, which hopefully will support and help the NHS. There's a session going on in the Lomond Auditorium at the moment talking about that very thing, and hopefully get some reliable real-life data to augment the clinical trials. We cannot mention managing bladder cancer without touching on prevention, not only in reducing the risk of developing bladder cancer, but also helping with outcomes. So the first area is actually at the beginning, following diagnosis of bladder cancer, we need to be quite effective in carrying out the initial operation. It affects the entire spectrum of bladder cancer, particularly the non-muscle invasive bladder cancer, which is the huge chunk. Quoting someone who's been in the business for ages, the quality of surgery used to assess and treat bladder tumors is critical to a successful outcome. Urologists have no control over the extent of disease, but can control how they evaluate and treat patients. The who and how of surgery in bladder cancer does indeed matter. Having previously suggested that the detrusor muscle is a useful surrogate of quality, it's nice to see that the SEER database has assessed this further, looking at the association between absence of detrusor and outcomes. And in all cancers, it actually does pose a poorer outcome in terms of survival. The pickup of detrusor muscle, if you think of it as a quality or a staging parameter, we have not been doing very well. Maybe having dedicated lists is helpful, and certainly having QPIs, in my experience, has been helpful to bump up the pickup of detrusor muscle. It's all about the attention to detail in bladder cancer surgery, especially at the start, and with having something as simple as having a checklist and moving up from 5 to 8 items on the checklist may increase the ability to pick up detrusor muscle. Level 1 evidence, mitomycin C. We've not been great at doing that. Maybe call it a carrot or a stick. The QPIs have certainly helped us in Scotland bump up the usage of mitomycin. We spoke about poor communication. We now have several avenues where patients can be referred to. We need to be using these more frequently in our clinics, and particularly the use of buddies has been quite helpful. Of interest within the realm of effective surgery is a clinical trial that we are all contributing to, and hopefully in the next 3 years we'll get good data on the cost effectiveness of PDD, and certainly important for the NHS. So we try to line up all these ducks in one row, if you may, the who, how, what, and when. I think the future will be, and many centers are now having dedicated lists with ring-fence spaces to ensure that we get our new tumors, the re-resections, the recurrences, etc. done. And these should be populated by local teams, or maybe an individual who's interested, through triage and ensuring good communication with the patients. And then afterwards, contributing to a national audit of TURBTs. We just spoke about that, Joe. And well, we've already started them with the QPIs. The next section is high-risk non-muscle invasive bladder cancer, and there's no better example of where effective initial surgery is important. It's a huge spectrum. There's significant heterogeneity. You might call it Jekyll and Hyde or chalk and cheese. We need to know which high-risk non-muscle invasive bladder cancer behaves badly. We don't have reliable molecular markers, so we rely on clinical acumen, clinical predictors, and one of which is the residual tumor at the early re-resection. But should we be doing early re-resection? It's slightly counterintuitive to what I said earlier about effective surgery. So with PDD, for example, the risk of recurrence or residual disease has dropped, as has understaging. Maybe we should be only re-resecting patients when detrusor muscle is absent. This could safely be carried out within the framework of the MDT recommended by local audit. The second aspect is actually getting these patients in within the 6 weeks, and there is evidence to suggest that if patients don't get in within the 6 weeks, it's detrimental to their survival. Thanks to the QPI, we've managed to measure where we are. I'm not sure where we are nationally, but I think 76% is still quite poor. BCG, we've been using BCG for several decades now. The two problems are failure of BCG and the shortage. While cystectomy could be considered the gold standard, it's not for everyone. It's nice to see that the Bravo team have now started looking at feasibility of randomizing patients into surgery and immunotherapy, so we need to watch this space. The Guy's team have very elegantly carried out a study looking at MDA mitomycin with sequential BCG. They've used all 6 BCGs at the induction. Certainly the tolerance was okay. Recurrence-free survival was great. And if you look at their longer-term outcomes, I think this is the new benchmark of high-grade non-muscle invasive bladder cancer recurrence rates. It's nice, it's low, and the progression risk is only 3%. Leishon and team in Leicester have used the Combat BRS system for sequential heated mitomycin and BCG. They've only used 3 BCGs in the whole 1 year of treatment, and in exciting results, 88% 1-year disease-free survival with a low progression risk, and the compliance is quite good. So building on that experience, BAUS has recently supported a proposal for the HIVAC-3 trial led by Joe Cresswell using the Combat BRS system. So hopefully this is keeping it simple, just comparing heated mitomycin versus BCG. The future, of course, is potentially the use of checkpoint inhibitors, not only for failed BCG, but maybe as primary treatment, depending on the side effect profile. The next area, when we talk about surveillance, the first thing that crosses our mind is it's costly. Cystoscopies are the mainstay surveillance techniques. Should we be starting to look at DNA in the urine? Certainly with the Euromark test, John Kelly's team have shown a very impressive ROC curve, certainly very much better than the test that we've known about in the past. The group are now looking at 2 studies, the DETECT 1 and 2, which hopefully when we get results will be quite exciting as well. Should we be resecting or diatomizing all patients? Hugh Mostovid is doing this study called Caliber, which is using mitomycin for chemoresection. Muscle invasive bladder cancer and advanced disease. We must remember that muscle invasive bladder cancer is a small proportion of the whole bladder cancer population. And of them, we can potentially treat maybe 50%, we can cure them. The remainder, including the group that is presenting with advanced disease or not fit for surgery, should receive a lot of support right from the outset. And actually a referral to the palliative care team at the beginning would very much be helpful for the patients. And we're slowly starting to see a paradigm shift in the way we actually demarcate curative treatment and palliative treatment, and I think it's very relevant, especially where muscle invasive bladder cancer is concerned. When you look at radical treatment, it's quite humbling to note that only 1/10 of our bladder cancer patients get major surgery. Our oncologists help us with the vast majority of these patients, and one of the studies of relevance to the NHS would be the Rader Trial, where Rob Haddad and team from the Marsden are looking at focused beam of radiation, potentially to reduce the side effects. Touching on robotics, is there a role for cystectomy using a robot? There have been randomized controlled trials, meta-analyses, and the commissioners have certainly not supported the advancement of robotics in cystectomy. This is supported by the systematic review by John Kelly and team, demonstrating that in extracorporeal joints, there is no added benefit to be gained from robotics in cystectomy. The group are looking at intracorporeal anastomosis and reconstruction, emphasizing that the open radical arm should have high volume surgeons carrying this out, and with an emphasis of enhanced recovery. And this is essentially the message as far as cystectomies are concerned. It's the volume. Whichever technique you use, whether it's open surgery or robotics, is a volume that translates to useful outcomes, not only in perioperative mortality. I think we can rescue more patients when you have more experience. And also we're now looking at evidence to show that higher volume centers have better survival long term. All this is coming together with suggesting centralization. We need to have more centralized centers, and it's nice to know that 87% of centers carrying out cystectomies are compliant with the NICE 2002 guidance. And that has now translated to improved mortality figures and also survival. Every modern cystectomy practice should have enhanced recovery as part of our motto. This should be the way of life when we're carrying out cystectomies. And not to forget the frail patient who can scupper the figures would benefit from us working together with our medicine of elderly colleagues. Many centers are starting to have comprehensive geriatric assessments. And what I would consider the red line being wheels coming off can very easily be moved up to a simple wobble with some prehabilitation. And last of all is we need to start thinking about how we measure outcomes. Traditionally, we've been using survival curves to inform patients. Patients now want to know how they experience recovery following surgery and also the longer-term side effects. This is where PROMs come in. We have more information about the quality of survival and the impact on the patient's function, i.e. quality of life. We have PROMs for bladder cancer now, and potentially this could form the benchmark for going forward. This may be the future in counseling when we see the patients in the clinic. Not only do we show them our Kaplan-Meier curves, but also the PROMs data, and potentially we could create a nomogram. So in summarizing, I'm going to try this out. So as we exit the European Union, it would be ideal to unite with an emphasis on efficient processing of patients led by expertise in carrying out expeditious and effective surgery, coupling engagement with all stakeholders, eloquent communication in providing equitable standards of care, using equipment and technology responsibly, while exploring new treatments with equipoise measured against universally accepted endpoints. Thank you.
Thank you, Pam. That's a great 15-minute run through contemporary bladder cancer. We've got a question through on the iPad for you here. It says, is there a case for bringing obvious muscle-invasive bladder cancer into the cystectomy centre pre-TURBT to reduce delays in treatment?
Absolutely. I think if we can, there's two ways. One is the cystoscopy. The cystoscopy with experience is now able to discern between what looks like a muscle-invasive cancer and non-muscle invasive. So that should come into the cystectomy center. And I think there's proposals for trying to do MRIs right at the outset. And that's quite a useful tool to be able to separate muscle invasive and non-muscle invasive. I would agree they should be coming. In fact, they should be having the TURBT done by the cystectomist so that you can have a thorough assessment.
Thank you. I think in the interest of keeping to time, we better move on to our next speaker, but I'm sure you can catch Param afterwards if anyone's got a burning question for him.
So our next speaker is Declan Cahill. He's a guy I've known since medical school in 1989. Some of those stories will have to stay quiet for the moment. He spent 12 years as a consultant in Guy's before moving to the Royal Marsden in 2015. He's a real prostate cancer expert, high-volume surgeon with excellent outcomes. So looking forward to your talk, Declan.
Good morning. The Brexit may have many implications on prostate cancer, both direct and indirect. And I'm going to spend 3 minutes on the indirect, which affects all of us in this room, no matter what we do. The largest threat from Brexit is to our workforce. 10% of the medical workforce and 5% of the non-medical workforce are European and from the EU. The BMA are working hard to make sure that we give all the medical researchers and the EU doctors currently in the UK permanent residence, and we need to work towards some flexible immigration. We work very closely alongside many people, nurses, porters, cleaners, social care staff, all EU nationals or from non-EU. And there's a huge number of Filipinos and EU workers who we're very dependent upon in the hospital. There's been a 96% reduction in nursing applications to come and work in the UK. Now, that is partly due to Brexit and partly due to the increased language standards which are required for entry. And it's also issues to do with an effective pay cut. There's a 1% pay progression on the NHS against higher inflation. And then to boot and to complicate that, the bursaries for nursing in the UK have been withdrawn. And so nurses are having to borrow large amounts of money to go through university to get a nursing degree. There's been a 23% reduction in application for UK nursing degree courses. The other important thing we have to do, we have to retain the staff we have. And so the staff we have, they mustn't be encouraged to leave the UK. They need to be valued. And so everyone in this room, we need to communicate that they are valued and they are welcome. Hospital rotas and hospital shifts are under strain. And if we have a further loss of workforce, we'll put more pressure on those systems, and there'll be an increased drain, which is already happening from the indigenous staff, further complicating the problem. It is vital that we maintain the UK's ongoing access to EU research programmes, research funding, researchers, research projects, and the regulatory environment. A lot more money comes into the UK for research than goes out from the UK to Europe. £300 million was the net benefit from Europe to UK since 2014. Now, it's likely that Brexit will cause economic uncertainty, and the NHS budget reflects the pressure of the economy. So it's likely NHS funding will come under pressure. Regardless of this, we have to provide an evidence-based service for our patients, and it needs to be cost-effective. This is corporate governance. This is corporate governance to your hospital and to the NHS. So we need to practice cost-effective medicine, and we need to make cost savings in what we do. I'm going to address the specific of prostate cancer along diagnosis, treatment, surveillance, surgery, radiotherapy, pharmacotherapy. I'm going to address a little bit on follow-up. The PROMISE study has shown that pre-biopsy MRI is better than trust biopsy at diagnosing prostate cancer. It may reduce unnecessary biopsies by 27%. It may reduce the clinically insignificant disease by 5%, and may increase our pickup rate, so reduce our miss rate of significant disease by 18%. And as also referenced on the slide there, the health economics apparently stack up. This is, of course, dependent on our ability to standardize the quality of MRI reporting. Systematic reviews publish very broad ranges of the negative predictive value and specificity of MRI, and so this isn't a given. Although, to be fair, in this paper, both the UCLH data and the non-UCLH data were similar. So it is able to train up and improve MRI reporting. The results assume we can provide targeted biopsies, and it assumes the definition of significant disease is correct. So the significant disease was defined as Gleason 4+3, or greater than 6 millimeters of any cancer length on a core. Now, 43% of men were stated to have clinically significant disease based on greater than 6 millimeters of cancer that was 3+3. That is not life-threatening disease, and if the health economics and the stats depend on that as a definition for clinically significant disease, the data is in doubt. Now, despite this, no one in this room would have a prostate biopsy without an MRI first, and PROMISE is the best evidence that is the correct thing to do, so somehow we have to make it work, because it's the information we have. So active surveillance. So the standard MDT mantra when we have clinically localized prostate cancer, that the patient should be offered all options, is now a complete nonsense. It is clear that looking for prostate cancer is our only hope of reducing life-threatening disease, but at the cost of substantial overdiagnosis of clinically insignificant disease, and that is expensive as well as harmful. CLOTS has been validated now by PIVOT, and most lately, PROTECT, that low-risk disease doesn't benefit from treatment. So active surveillance saves on treatment costs, the cost of managing functional issues and complications. However, the optimal surveillance protocol is unclear. We know that PSA kinetics are unreliable, and from the probe section of PROTECT and from the prior study, that biopsies are often unacceptable. We need to learn to use chronic disease management lessons to care for these patients, not to overly actively survey very low-risk disease, and to reduce the need for clinic interaction but still get remunerated. MRI is probably the solution for this. SPCG17, the Swedish prostate cancer group, study number 17, prostate cancer active surveillance threshold study will soon be open at the Royal Marsden and Guy's Hospital looking at this question. Now, all radical treatment options for clinically significant prostate cancer is also a poor MDT mantra. We lack randomized evidence between surgery and radiotherapy, but the comparative evidence that we do have clearly suggests that surgery is better. 18 out of 19 of the large comparative studies show significant advantage for surgery. And certainly there's bias involved. But all things being equal, and to be fair, they very rarely are, surgery is better than radiotherapy. The second reference is a very nice editorial on the meta-analysis, highlighting some of the weaknesses, helping us keep our feet on the ground. There's 7,500 cases are performed, robotic radical prostatectomy in the country. 80% of them are robotically done by 169 surgeons in 74 centres. Year on year, less patients are having a radical prostatectomy for Gleason 3+3 disease. We're doing well. The median number of cases has risen brilliantly. I remember at the beginning of this decade, although the data was obviously incomplete, but the numbers per surgeon were as low as 9, 13, and 16 in three consecutive years. But 38 cases per surgeon is good, and there's fewer surgeons doing just a few operations. This has been achieved by the BAUS radical prostatectomy audit and publication. This plot is number of cases versus positive margins. Now, radical prostatectomy is difficult. It is very difficult to perform a good cancer operation safely with good functional outcomes. Now, I'm the red dot on the right of that graph, which at this time I can say I'm very proud of. However, the truth of this graph is that I have been every dot on that graph at some point. So what is most important to us as a group is that you, or we, constantly move this side, so we're doing more cases. If not more cases, we're getting better results. So measuring what they do, the surgeons that you refer to, they need to measure what they do, they need to make themselves better, they need to do more, they need to communicate it to you, and they need to earn your referrals. So the next phase of centralization, increasing the volume equation in radical prostatectomy, is going to happen at local level by the referrals. My point isn't lost on this subject. High-volume surgeons spend less time per case. They do more cases for the same money. They've lost less ongoing costs from complications and the functional shortcomings of treatment. They are more efficient. Over the 7,000 cases of robotic radical prostatectomy, to take one possibility, using one needle holder instead of two saves £1.5 million. And the same equation occurs to unnecessary use of hemostatic products. And of course, doing 3 cases in an operative day instead of 2 is 50% more efficient. So volume counts. Now radiotherapy. The CHIP trial has published and has demonstrated that 20 fractions of radiotherapy are as good as 37. And that's for prostate-only treatments. If it's prostate and nodes, so whole pelvic treatment, it's still 37 fractions. That's a significant cost saving. It's better for patients because they've got less visits. There's no more morbidity from the higher dose per fraction, and it is just as effective. However, as with a lot of these things that you'll see, there are significant impacts other than that, and this one, for instance, leaves a hole in department budgets that needs to be thought about. The Stampede trial has shown that 6 cycles of docetaxel is a standard of care with androgen deprivation therapy for metastatic prostate cancer for all fit patients. This has a cost and has been a delivery shock. It's been a delivery shock in delivering that treatment in departments across the country. Stampede is causing more trouble by way of the currently very expensive abiraterone. Adding abiraterone to standard androgen deprivation therapy improves survival by 37% at 40 months, currently £30,000 per year. Janssen is fighting the loss of patent But if they fail, it'll become much cheaper, and that'll be good for all our patients home and abroad. Follow-up. Release from secondary and tertiary care is potentially a very positive step in the cancer journey and is easily done in prostate cancer. With PSA and the concept of symptoms or no symptoms, the need for review is less, and transfer of patients from secondary and tertiary care to primary care is easy. It's good for patients. It liberates us to do other things and spend more time on patients who need us more. They're remunerated, so we get paid for this huge backlog of worthless follow-up. If we lose that quickly without altering the way tariffs are paid and we are funded, will cause significant funding in the departments. This is work in progress across all the cancer networks. So, in summary, the impact of the workforce from Brexit is the biggest threat to us all in everything we do. We need UK residency for those that are here. We need flexible immigration for those that will come. And we need to retain staff and make sure the ones that we have are valued and are felt to be and made to feel welcome. Our leaders need to lobby the powers that be that this happens. Brexit will cause economic uncertainty of unclear proportions, so there's likely to be cost pressures that we need to anticipate. However, 2016 and 2017 has been a year to be very proud of British urological oncology. With the previously mentioned studies, PROMISE, PROTECT, CHIP, STAMPEDE, all very positive game changers for prostate cancer patients to benefit both home and abroad. Thank you.
Thanks, Declan. Any questions, please? Hands up. Just wait. Declan, I've got one quick question. We're so reliant on the MRI scan now and the quality of that report. How can we be sure that we're getting good MRI reports in our individual centres, and how do you validate that?
Well, I think it's very easy to, just through the MDT, to validate, are you biopsying the right people? So comparing the MRI report to the biopsy outcome, so was that a good decision? And then from that will deliver enough information on the quality of your MRI. And there are steps afoot to try and increase the training, improve the training, and it works. It worked in CHIP. So the non-UCLH centres did as well as UCLH, which means the mantra of these studies are all about UCLH and not about anywhere else, is perhaps unfair and can be worked around.
Great. Okay, thanks very much, Declan. We'll move on.
So for our last talk in this session, can I introduce Simon Hughes, the urologist from Guy's have kindly brought their oncologist north of the border for a little break. Simon is treasurer of the British Uro-Oncology Group. He's a co-opted member of BAUS, and he's a past president of the oncology section of the Royal Society of Medicine.
Good morning. So thank you for inviting me to the BAUS meeting. I think I now make it a multidisciplinary meeting, don't I? So I'm going to talk to you about what the urologist needs to know about uro-oncology. So as with every oncologist talk, start with my conflicts of interest. So I think over the last few years, we've been very successful in oncology and cancer at characterizing tumours at the molecular level. And as a result of that, we've managed to devise various molecular targeted and pathway targeted treatments that are revolutionizing our cancer care. And we've got various buzzwords for describing this. So we call it stratified medicine, personalized medicine, precision medicine. So I was wondering, if I came along to BAUS, could I contain your excitement with 15 minutes of Kaplan-Meier curves? We've got an example here. This is an agent that's just come out, costalotamab. Compared against the standard, you can see we've got a hazard ratio that's significant here of 0.7, so a 30% improvement in outcome. And I was thinking, you've had some excellent talks during this conference. I've looked at the program. You've had people talking about the latest treatments available, talking about molecular profiling, so I don't want to go and repeat all of that. So what I thought would be useful with Brexit coming through is that we're going to be increasingly constrained with resources. And in oncology, we've been using expensive drugs for a while now, so we're used to people looking at the cost value of our treatments. And I think that what we've been experiencing is going to be sort of becoming real life for urologists as well going forward. So I thought I'd talk a little bit about that. Just before I move on, in interest of probity, Costalotomab doesn't exist yet, so if any pharma companies are looking for a name, this is still available. What this is actually a Kaplan-Meier of is quality streets versus roses and their survival on a ward. It's a meta-analysis published in the BMJ. So I'm going to talk about health technology assessments, which we've been mainly using for drugs up till now, and how this may be expanding into radiotherapy surgery. A little bit about the Baumol effect and price differentials across Europe. And then a very quick bit about the economic burden of cancer and how we may be able to assess that better, and that may have better sort of impact on us modelling how we can decide whether we can afford drugs or not, or other treatments. So this is where we are now. The person climbing up the cliff there, that's sort of the NHS, that's a private health insurance, as a commissioners, and they've got a tidal wave of cost heading towards them. Meanwhile, as an oncologist, I'm surfing the big kahuna here because we've got all these agents coming through, we've got loads of developments coming through, and at some point there's going to be a clash, and this is what we have to try and control. So we've all heard of NICE and the Scottish equivalents, and NICE has multiple roles. Quality standards, they set guidelines, clinical, public health, diagnostic. They do a lot of work sort of assessing interventional procedures, whether there's an evidence base for them. But they've also do technology appraisals, and these are different from the other aspects of NICE in that these have a funding directive. If they assess a technology and they say that we should offer it, then everyone has to offer it on the NHS. If they say that it isn't cost effective, then we aren't allowed to give it. There's no funding for it. And we've been using this for drugs, because it's quite easy for a drug. If you decide that we're not going to carry on giving a drug, you just take it off the shelf. The issue we've got with more complex radiotherapy and surgical techniques is you've already bought the kit. If NICE now turn around and say, actually, no, we're no longer going to fund this, what do? There's a huge outlay, and that's not efficient use of resources. So that's why the NHS is now looking at this commissioning route, and it's yet to find its teeth, and there's lots of debates going on, but they're now trying to look at whether the incremental improvements with newer techniques are actually cost effective. And this is slightly challenging because we haven't been in this position before, so we've done the studies previously to develop our new techniques, and we haven't collected the relevant data that they're asking for to prove the benefit. And that's why I thought I'd talk about what we've been collecting and where I think this is going. And I think we need to actively engage in this process to make sure we're collecting the correct data to optimize what our patients are actually going to receive. So these are the health technology appraisals we've been involved in. So I've looked at the uro-oncology ones on the left and the urology ones on the right. So there have been some urology health technology appraisals, mainly around immunosuppression, renal transplantation. But we've had a whole host in uro-oncology. If you look down the bottom there, it doesn't come out too well, but 2016, we were constantly attending meetings, writing reports. And a lot of these are favourable. Now, if you get an unfavourable assessment here, that doesn't mean the agent isn't effective. This is it cost effective? So a lot of this is related to price. And it looks quite a simple process. We put a drug up, we have a health technology appraisal, and then we decide based on that whether it's funded or not. But the actual process can take months to a few years, in that we go in there, we start a debate, we come back, and we need more information, we need more modelling, we need more quality of life data, so it's usually an ongoing process with multiple steps along the way. And what NICE are doing with these economic evaluations is looking for cost effectiveness. They're comparing one treatment against the current standard of care, and they're making a value judgment for that. And the units they use are QALYs, so quality of life year, or quality adjusted life years. So one QALY is perfect life for one individual for a year, or it's perfect life for two individuals for half a year. So if you look down on the bottom left here, we've got two treatments. One costs a mean of £10,000, the other £15,000, and the difference between the QALYs is 0.1. So we end up with an incremental cost of £5,000 per 0.1 QALY. So we have something then called an incremental cost effectiveness ratio, which basically means for every QALY improvement with this particular drug costs £50,000. We then have to set a threshold, and the threshold for NICE is £20,000 per QALY, basically. There's a bit of wiggle factor, so this drug wouldn't get in. It's way above, so you have to reduce the cost or find other improvements in quality of life to justify it. And that's why the health technology appraisal round goes round and round and round, with different data being presented. It's not set in stone at 20. There's a bit of wiggle room. If there's unaccounted for health gains, end of life is a different situation, if it's a significant innovation. So there is a bit of wiggle factor. And if you look at all the evaluations that have happened so far with NICE, if you look at 20,000, which is about in the middle there, if something's blue, this is a drug that's been approved, and if it's red, it's been refused. So there's a few down the cheap end, which we just don't think are effective. And there's a few in the more expensive end that have been approved. And now this shows that although NICE is setting the threshold and making decisions, it is open to influence. There's a lot of political influence with NICE as well. So you can campaign, you get your local MP to go to government, and then suddenly it gets funded. We've also had the National Cancer Drugs Fund, which was another very politically driven method. So if NICE had approved a drug and then decided it wasn't cost effective, you could still get the drug on the National Cancer Drugs Fund, and 55% of drugs on there have been turned down from NICE. So it's very much undermining the whole process. It's all been revamped now, so we now use the Cancer Drugs Fund to pay for drugs whilst the NICE evaluation is, or the HTA evaluation is going on, rather than trying to keep the drug going after NICE have already said no. And this is what we've found with prostate cancer. So we've got all the drugs that we've been reviewing, and it doesn't look, according to this graph, like any patients have really been disadvantaged. If you look at the red vertical lines, that's when the marketing authorization came out, and the yellow vertical lines are when NICE published their appraisal. And if it's in green, it means we've been able to prescribe it. If it's in sort of browny orange, we've been able to prescribe it on the National Cancer Drugs Fund. So most of these agents have been available. I think one of the interesting ones to look at is the abiraterone pre-chemo midway. You can see that took 2 to 3 years of negotiation to actually get an approval. All the time we could still give it to the patient. So if you don't have a National Cancer Drugs Fund, if you don't have a National Robotic Surgery Fund to fund whilst these decisions are being made, then that does withdraw the treatment from the patients. The other interesting one is the second line, cabazitaxel. A lot of that delay was because we didn't have decent quality of life data. These studies were designed years ago. We weren't sure at that point that NICE would be looking at quality of life data to make the decision, so we didn't have the data available. It delayed the final decision coming through. So I think that's why I think it's important to engage in these processes, think of everything they may ask for and collect the data now, otherwise it's just going to lead to delays in decisions being made. So that's drugs, and I said, so drugs were very easy to target. Look at the trials, you decide whether you're going to fund it or not. But if you look at non-drug expenditure, so this is European data, and we've got the UK ring-fenced there in green. On the far right-hand side of those columns is the drug expenditure. So you can see for prostate, that's quite significant, but for bladder cancer, there are far more other things to target. There's inpatient stay, outpatient follow-up. So we've already targeted the drugs for health economics. Now they're going to be looking at the rest of the pathway, and that's where radiotherapy as an outpatient treatment comes in. It's where intravesical bladder chemotherapy comes in, another outpatient treatment. It's where surgery comes in, that's an inpatient treatment. So this is where it's coming next. So I wanted to look at how we would fare in health technology appraisals now, looking at sort of minimally invasive robotic prostatectomies and IMRT, which is the sexy radiotherapy we now use. And this is a paper from Paul Newen from Harvard, looking back in the 2000s when we introduced the technology. So on the left, the blue columns are the standard technologies. So the top one is open prostatectomy, the bottom one is 3D conformal radiotherapy. And you can see over just a few years how we adopted the new techniques as they came through. At the same time, if you look at the costs in dollars, the newer technique was far more expensive than the traditional technique, and there was very little data around at those times to support the adoption of the new technique. And this is why everyone's now looking so carefully at any new technologies coming through to make sure they're cost effective. The spanner in the works is if you look over time, the newer techniques get cheaper. So at what point do you make your decision that this newer technique is cost-effective or not cost-effective? Because with time and technological advances, it's all going to become cheaper at each point, so you need to keep reassessing. So with radiotherapy, on the left-hand side, we have no randomized controlled trials that IMRT is better than 3D conformal radiotherapy. We've never done them. We've done planning studies, and we've looked at retrospective analyses whilst we've already been doing it. When we plan radiotherapy, we look at the CT scans, we look at the dose distribution, what percentage of what organs receive in what dose, and we can predict toxicity. So if you look at the top one, that's a 3D conformal plan, and the bottom one's an IMRT. And you can see the rectum is in the red zone on the 3D conformal, but it is in the green zone, which is a lower dose of radiation on the IMRT. So we can predict what the toxicity is going to be here. Do we need to do a randomized trial? We do for health technology appraisals, but actually, is it ethical? And that's why I call this the parachute justification. And this is a paper from the BMJ. And they tried to do a systematic review on randomized controlled trials with the use of parachutes to prevent gravitational injury. And surprisingly, they couldn't find any papers looking to see whether parachutes worked or not. And the argument is, do we need to do the same for these technologies as well? We do for an appraisal, but maybe not clinically. So this is the Baumol effect. So Baumol, this is a paper written in 1966. And what Baumol was arguing was if you're in a manufacturing industry, with technological advances, it becomes quicker and cheaper to make products, so your output improves. Whereas if you're in a service industry like education or health, although there are technological advances, there's a human factor. A robot can build a car, a robot can't take a prostate out. So you're limited by the human factor, and yet resources and technological advances are more expensive, and you have to try and balance the salaries. Otherwise, everyone moves from service to manufacturing, and that's one of the problems with this 1% pay cap at the moment on nurses. So we have an inherent problem in the system in that healthcare is going to become more expensive, and yet without an increase in output. We then look at health expenditure. So across Europe, we've got the data looking at the cost of drugs. So a new drug comes out, and we can find the differential cost around the advertised price can be from 28% to 388% of the advertised cost of that drug, depending on what country you're in. You can then look here. This is the expenditure and outcomes. On the left is a cancer fatality index. So the lower the level, the better. And on the right, on the bottom, are costs. So as cost goes up, so that little dot there on the right-hand side is Greece, actually your cancer fatality index may go up. You can get worse outcomes. There's a complete disconnect between how much money we're spending at the moment and what our outcomes are. Encouragingly, UK is in the middle purple bit there, and we're actually not spending very much and getting very good outcomes. So we're already on the left-hand side of the curve here. I'm not sure how much further we can go. And if you look at prostate cancer, it's even worse. The more money being spent across Europe in prostate cancer, the worse the outcomes. So there is definitely an argument here for economic sort of control of new technologies. But having said that, we're on the left-hand side of this curve. We're doing well and we're very cost efficient. How much further can we go? So rounding up, I wanted to look at where we're going to go going forward. So at the moment, we look at society, and society sets a cost they're willing to pay for an increment in quality of life. Is that really a sensible thing of doing it? We're looking at society imposing something on an individual. And I think if we're going forward, we need to look at the greater economic burden of cancer. We don't need to just look at quality of life. We need to look at, on here, healthcare costs, which are the dark blue, indirect healthcare costs, informal care, whether people's partners have to take time off work to look after them. Then the impact on industry, on income, which is red, and then volunteer sector as well, which is an orange there. And I think going forward, if you're really going to truly assess the impact of a treatment on society and whether we can afford it or not, we need to take all of this into account. So if you move on to here, so we've got a little bit of the macroeconomic burden. We've got cancers, ischemic heart disease, stroke, dementia. Look at dementia. Dementia's got a lot of healthcare costs and informal healthcare costs. And we'd do a study, we'd look at whether the improvement of quality of life in an individual, and maybe the drug's more expensive. But if you could prove that actually by increasing someone's functioning, you can reduce the level of informal care, allow people to get back into work, increase productivity, you might have a stronger argument for your drug than just looking on the individual level. So years ago, we were looking at just looking at if we gave you a drug and you lived longer in oncology, great, you should be happy with that. Then we accepted we had to start looking at quality of life because that's important. We're then putting in translational studies to see whether we can predict outcome, because then we can cone down and just give the treatments to the patients that are going to respond. And I think going forwards, we're now going to build in macroeconomics to most of our studies as well, looking at the populations we're serving and whether, as an overall economy, we can actually afford the drug rather than just setting a target for the individual. So in summary, I think we're going to have continued innovation. There's going to be a greater emphasis of the cost outcome gain, and it's going to be procedures and pathways as well, not just drugs. I think the health technology assessments at the moment are quite a blunt tool, looking at quality of life years. And I think really looking at assessing benefit in future, we need to decide with a society and individual and use economic modelling as well. Thank you.
Well, we have people filing in for the next session, so I think we'll need to bring this session to a close. I'm glad to see that the future of urology looks strong and stable post-Brexit. I'd like to thank all our speakers. I think it's been excellent and very thought-provoking, and I wish you a pleasant rest of your stay in Glasgow.